All right. So this is Jessica Gibson. I am CEO and co-founder at Ariel Precision Medicine, and I am so thankful to be here today, co-hosting this webinar with the National Pancreas Foundation, which we've partnered with to bring this webinar to you on pancreatitis facts and fiction. The National Pancreas Foundation is a patient advocacy group providing hope for those suffering from pancreatitis and pancreatic cancer. They fund cutting edge research, advocate for new and better therapies, and provide support and education for patients, caregivers, and healthcare professionals. And today we have Dr. David Whitcomb. He is the CEO, he is the co-founder and chair of the medical advisory board at Ariel Precision Medicine, and Dr. Mark Haupt, who's the chief medical officer at Ariel Precision Medicine. And thank you all for coming and joining us today for this webinar. Dr. Whitcomb.
Thank you. I'm Dr. David Whitcomb. I have dedicated my life to studying the pancreas to try to understand when it goes wrong and not only how to cure disease, but how to prevent disease. And I'm excited to be here today and talk to you about some facts and fictions about pancreatitis. Some of the key concepts we'd like to talk about today is pancreatitis is a complex disorder and no two cases are alike. A second concept is that alcohol is a major contributing factor for pancreatitis in some patients, but not others. And the third concept is that genetic background of each person can guide current and future therapies as we understand why each person is unique and what to do to help them. I'd like to start with chronic pancreatitis because this is the end-stage disease, and this is what we were taught in medical school. The clinical characteristics of the disease are summarized on the left, and a CT scan of a patient with advanced disease is shown on the right. Now, there's a number of arrows showing all the different complications that can occur, and we're not going to go through those today, but I'd like to summarize by saying that there is about 80% of patients with this disease that have severe scarring. About 40% have maldigestion. About 35% have diabetes. 70% have pain, but there's different types of pain, some constant, chronic, severe, episodic, and then pancreatic cancer is a concern of everyone that has this disease. So the reason some people have a mix of these in different ways and have some and not others is not understood. So how do we diagnose chronic pancreatitis? Well, the diagnosis requires demonstrating irreversible damage. Physicians call this the Cambridge definition. And in order to make a diagnosis, the pancreas has to be destroyed. Now, we could take biopsies, but that's very dangerous. So we use CAT scans and MRIs, ERCPs, or endoscopic ultrasound as imaging of the pancreas that tells us what the pathology looks like. And when it looks so bad, we know the disease is there. At this stage, we can only do symptomatic therapy. We can't reverse the disease. We give pain treatments, which are often not very good, pancreatic enzyme replacement therapy in case the pancreas can't digest the food anymore, and insulin in case the pancreas has been destroyed to the point that the insulin-making cells are also destroyed. So what do we have? What is the starting point here if we begin looking at chronic pancreatitis as the beginning of the process? We have a complex, irreversible condition that's expensive to diagnose and treat. This is a terrible place to start, and we want to understand why people get this in the first place, because generally it develops over time. Now, chronic pancreatitis in the 1800s was discovered to be inflammation without infection. And 100 years of research was summarized in this paper in the New England Journal of Medicine. And what the Harvard experts told us was that chronic pancreatitis, after 100 years of research, remains an enigmatic process of uncertain pathogenesis, unpredictable clinical course, and unclear treatment. The traditional way of approaching this is a complete failure. We have to do better. Now, this is what a normal pancreas looks like. And what you see is that most of it is this deep purple, and those are enzymes that are going to be squirted into the intestine to digest the food. In addition, this arrow points to an islet of Langerhans. These are the cells that produce insulin, and the insulin is released into the blood so that it can signal the cells to pull the sugar out of the blood as the sugars are being digested and absorbed in the intestine. Now, we understand that some people start getting chronic pancreatitis, and what you see here is a similar picture of a piece of pancreas from a patient. And now there's these pink things, and those are fibrosis and scar tissue that's beginning to choke out the cells that make insulin and choke out the cells that make digestive enzymes, until finally, severe chronic pancreatitis is only a scar. The rest of the pancreas is gone, and that's why it's irreversible. Now, how does this begin? Well, what we've recently seen in the top left is that most people have no pancreatitis. About 1% will develop acute pancreatitis. This is a flare that comes on suddenly and normally resolves. But in about 10 to 20% of patients, they get recurrent acute pancreatitis, start having episodes over and over again. And if they have that, then about 20% progress to chronic pancreatitis. Now, at the bottom, you see a diagram that the physicians use to try to map out each step and all the things that are happening. And what you see is, in the end, you have fibrosis, about 80%, exocrine insufficiency, endocrine, which is diabetes, pain syndromes. These percentages are in some people and not the other, but we can tease it apart to understand this process. Now, this is a tremendous model, and it has been very helpful because what it tells us is that with acute pancreatitis, you can start looking at early stages that can be prevented. Unfortunately, there are some patients who have chronic pancreatitis and they don't have recurrent acute pancreatitis. And in some studies, 30 to 40% of patients have no warning sign and they end up with chronic pancreatitis. And we don't understand why, but these patients tend to be older and they tend to have more of a shrinkage of the pancreas rather than a lot of the traditional findings. And so we're still learning how to detect both the ones with acute pancreatitis early and the ones that start having loss of function. Now, there are several different types of pancreatitis. It's not all the same. And so we're going to look at the etiologies or the causes of pancreatitis. And this is based on a study that we conducted in the North American Pancreatitis Study 2, or NAPS 2, in which almost 30 centers from around the United States worked for more than a decade to help understand that. And I wanted to point out the word idiopathic means that the cause is unknown at the time of the diagnosis. So what did the doctors in the NAPS 2 study decide that patients had when they presented with chronic pancreatitis? And this is a table from that study. What we see is that a lot of patients had alcoholic pancreatitis, but I put a circle around this in red because it means that there are a lot of genetic factors that are linked to pancreatitis in people who drink alcohol. Now, there is obstructive causes, but this is not caused by genetics. This is a mechanical obstruction of the pancreas, so the enzymes back up and cause damage directly. Genetic causes we're seeing in a subset of patients, but these are the traditional ones that run in the families. And you can look at the family tree and they say, yeah, my dad had it, my grandmother had it, her brother also has it. And so these are the ones that were traditionally known to be genetic. Now, idiopathic is the one where nobody knew what they had, but on further analysis, we found that the ones that had early onset had a lot of genetic factors associated with it as well. And so genetics were important here as well. Another thing is hyperlipidemia. This is fat in the blood, high blood fats that can cause pancreatitis. The reason people have that is also genetic. And there are other causes as well, and it turns out many of them are genetic. And so the key to understanding this early development of pancreatitis has a lot to do with genetics. And so this is what doctors are beginning to consider and to think about so that they can pinpoint the problem in an individual person and begin to find ways to stop the progression and return the person to normal health. So let me spend a little bit of time talking about alcohol, because the first thing a person with pancreatitis is asked is whether or not they're an alcoholic. The first thing, does alcohol cause pancreatitis? And the answer is no. That is fiction. The second thing we know is, or we would state, is that this statement, alcohol is a risk factor for acute pancreatitis, recurrent acute pancreatitis, and chronic pancreatitis. Is that true or false? And the answer is yes, that's a fact. So it does increase risk, but it doesn't cause it by itself. Chronic pancreatitis or chronic alcoholic pancreatitis rates are equal in men and women. Is that true? No, that is fiction. And we'll understand why in a minute. Genetic factors play a major role in alcohol-associated pancreatitis. Well, I already gave you the answer to that. The answer is that is a fact. So let's go to the first one. Alcohol causes pancreatitis as a fiction. What does that mean? Well, population studies are ones in which you look at a large group of people and see how many of them that are alike develop the disease. And what is seen is if you take 100 people from the community that drink a very high amount of alcohol, only 2 or 3 of them ever get alcoholic acute pancreatitis in their entire life. And of those, only 1 person gets chronic pancreatitis. How could it be the cause if most of the patients, more than 95%, have nothing going on in their pancreas their entire life? So it can't be a direct cause. Furthermore, animal studies, in which I've done many of these myself in our laboratory, if you feed mice and rats very high doses of alcohol for a long period of time, they never develop acute or chronic pancreatitis. There has to be something else triggering the pancreatitis in these models or these people in order for them to get pancreatitis. It cannot be alcohol by itself. So our conclusion is that alcohol does not directly cause acute or chronic pancreatitis. Now, I said it may cause pancreatitis as a risk factor, and here's some of the evidence for that. So here is a control population. So when we collected patients with pancreatitis, we asked their spouse or a friend who was about the same age and environmental background, how much alcohol they drank. And what we saw is in the general population, about 27% never drank alcohol, 31% drank a little bit now and then, 23% had a moderate amount, 13% were heavy, and 6% were very heavy drinkers. And so that's drinking a lot of alcohol every day. If you look at people with recurrent acute pancreatitis, you see that the proportions are very similar. However, there's a few higher percentage of patients that are very heavy alcohol drinkers in this group compared to controls, suggesting there's some effect, but most of the patients had something else. And with chronic pancreatitis, about 25% were heavy alcohol drinkers, and everyone else was something else. And so we see from this that in people who develop pancreatitis, a larger subset than expected are very heavy drinkers. And so this means that alcohol has some effects on the pancreas. Very heavy drinkers in women are 28 drinks a week, or about 4 drinks a day. And for men, it's 35 drinks per week, or 5 drinks a day. And the reason there's a difference is that men tend to be larger than women, and it's the amount of alcohol needed to raise your blood alcohol level to a certain degree. And so if the male is bigger, they have to drink a little bit more to raise the alcohol to an equivalent level. but that's a fair amount of alcohol. Now, this just shows how much drinking the people in each of these categories had, the light, moderate, heavy, but I want to draw your attention to the very heavy drinkers. The subset that had alcoholic chronic pancreatitis drank way more than the controls who were heavy drinkers. But the other thing that was interesting is that in our study, patients were not at an increased risk of pancreatitis unless they were very heavy drinkers. And so this tells us that there is a threshold before a person initially gets acute alcoholic pancreatitis. Well, that raises the question then, is that if there's this threshold, can a person who gets pancreatitis continue to drink? So after acute pancreatitis, is it safe to drink up to 5 alcohol drinks per day, but no more? And that is fiction. This is a very interesting study that came out of Japan, where they took everybody that had acute pancreatitis and followed them for more than 10 years, over 1,100 patients. And then they asked them 10 years later, what kind of pancreatitis did you have and how much alcohol did you drink before acute pancreatitis and in the oncoming years? And what you see under alcohol consumption is that some people stopped completely, some people decreased, but they still had an occasional drink. Others decreased the amount of alcohol but continued daily drinking, and others did as before. And what you see with recurrent acute pancreatitis, the more you drink, the worse you got, until you had very high risk, almost 60% got acute pancreatitis. How many got chronic pancreatitis? Over 40% with heavy drinking, less than 15% that stopped. And diabetes mellitus, here almost 40% got diabetes on top of that, showing their pancreas was severely destroyed by continued drinking. And so this shows that alcohol increases the risk of progressing to recurrent acute pancreatitis, chronic pancreatitis, and diabetes. So after an episode of acute pancreatitis, gotta stop drinking. Chronic alcoholic pancreatitis is equal in men and women. I told you that that is false. And so the picture on the right is a representation of men and women in the North American Pancreatitis Study Group, with twice as many men having moderate and very heavy drinking. What we see is that on the average, men do drink more alcohol than women, but that's not the answer, because if you take men and women that are drinking about the same proportion of alcohol, men still have twice as much pancreatitis as the women do. How can that be? It turns out the answer is genetic. And this is a fascinating story. It turns out the risk for pancreatitis is in a gene called claudin-2 on the X chromosome. And if you have that and get acute pancreatitis, you very rapidly go to chronic pancreatitis, especially if you drink alcohol. Now, the X chromosome is a sex chromosome, and males and females are different at these sex chromosomes. The other chromosomes are identical in men and women, but the sex chromosomes are different. And so the women have 2 X chromosomes, and the blue objects are illustrating the chromosomes, and a male has an X, and we call this one a Y. It's different. It's a little extra chromosome. And what's interesting is the claudin-2 variant changes the function on the Y chromosome. So if you're a woman and you have a defect in the claudin gene on one X chromosome, you have a backup. You have another X chromosome that can preserve the function. If you're a man, you're out of luck because the Y chromosome doesn't have a claudin gene on it. So when we take this into account, it turns that 26% of men, more than 1 in 4 men, and 7% of women do not have a normal claudin gene, and they're at very high risk of alcoholic chronic pancreatitis. So if you have if you're a man and you drink alcohol and have acute pancreatitis, you're at double jeopardy. Alcoholic pancreatitis also happens to have a variety of other variants in these other genes associated with pancreatitis: CFTR, SPINK1, CTRC, and PRSS1-2. And so when you think back at the 100 patients and why only 2 or 3 of them got alcoholic pancreatitis, there's a reason. And now we're understanding why. Now, this is also important. I just want to spend one slide on that. These are facts and fictions about smoking. The first one is it was believed that smoking had no effect on the pancreas. We found out that is fiction. It actually has a huge effect. How about this question? Moderate smoking, which is 1 to 2 packs a day, is a stronger risk factor for chronic pancreatitis than moderate or even heavy drinking. Is that true or false? As a fact, we're looking at the alcohol in one hand and ignoring the cigarette in the other, where the cigarette was even worse than the alcohol. Many chronic pancreatitis patients continue to smoke to relieve pain. Could that be true or false? That's actually a fact. And the way that smoking helps relieve pain is complex, but you know, it's a trade-off and it drives worse chronic pancreatitis. So there's a temporary relief, but in the background, it's causing destruction. So we need to think more about pain, and perhaps in the future, we could have another webinar when we can really look at this in more detail and understand where pain comes from and what's driving it and how to treat it. How about this statement? The majority of heavy drinkers are also heavy smokers, and the combined effect is greater than adding the independent effects. So if alcohol doubles your risk and smoking doubles your risk, and you smoke and drink, you'd expect the risk to be 4, but it's closer to 7 or 8. So the combined effects are really bad. Now I'm going to take a few moments to answer some questions about genetics. Detection of a pathogenic genetic variant is diagnostic of a disease. And I put in the bottom an explanation of what a pathogenic variant is. It means that the DNA is so damaged by mutation that it usually is associated with a disease, and you can trace the pancreatitis through the family or the diabetes through the family. These are very strong genes, okay? But the answer to the question is fiction. They don't cause a disease. What they do is they increase the risk. So you have to have both organ dysfunction plus the genetics plus evidence that the genetic defect is strong enough to cause the disease. And then the diagnosis is made by a clinician when they see the combination of factors meet the criteria for disease. So they're very important in helping the clinician, but they don't make the diagnosis, because some people have very bad mutations, and for reasons you don't understand, they never have disease. How about genetic risk factors for pancreatitis? Can they be common in the general population? That's a fact. It turns out that these risk factors are very common, and many, many people have it. Millions of people have them. But the patients with pancreatitis have a lot more than is seen in patients who do not have pancreatitis. So it's sort of like alcohol, where alcohol is a risk factor, but most people that drink don't actually get the disease. And the genetic risk factors are the same way. They contribute in some way, but they're not enough by themselves. How about this statement? Most people with pancreatitis have pathogenic mutations in a single risk gene. And the answer is fiction. There's actually only a small percent that have a single genetic variant. Instead, it's a combination of things that come from both their father and mother and interact with environmental factors. And so it's a complicated system compared to what we were taught in medical school, and that a single gene is going to cause a disease. It's actually more complicated than that, but we're beginning to understand how to think about it and how to diagnose it and how to understand what it means and how to stop the progression. So genetic testing of multiple genes in a patient with pancreatitis is used, and there's 3 answers. Is it used to determine which cell type or cell process is damaged? Is it used to help understand the cause of pancreatitis? Is it used to select possible ways to minimize the damage? And the answer is all of the above. So genetic testing sorts out all the possibilities and helps determine which cells are dysfunctioning, why, under what conditions, and that gives us some insights in how to start working to minimize the damage. So what is a risk factor? And I just want to spend a moment to talk about this, and I'm going to give a simple illustration about risk factors. So this has to do with automobiles. So here's a car up in the left, and there are risk factors for automobile accidents. At the bottom is a playground with a teeter-totter. And the question is that the teeter-totter going to be balanced, or is it going to tip to a bad outcome? Now, in driving, to protect people from accidents, you have to have a driver's license, and you have to be old enough and pass a driver's test and pass a medical exam and be socially responsible. You can't be an alcoholic or have multiple speeding tickets. And so that protects people from accidents. The car has to be inspected, and inside the car, there are also warning lights. On the road, there are traffic signs and signals. But if you are in an accident, there's the 5-mile-an-hour bumper rule and many car safety features. And there's also airbags and safety belts. So after the accident, there's also ways to protect you from getting injured in an accident. But accidents still happen, and people still get injured. There are some things that can happen that will increase that risk, such as poor visibility, maybe fog or rain. There could be a mechanical failure in the car or a road hazard that causes an accident. And these things happen randomly, and we try to prepare ourselves for that. But in addition, there are things that some people do anyway, such as they drive way too fast, and that's leading toward a bad outcome. They may be drunk or have some other impairment, and they may have other things that affect them as well. But worse than that, what if they disregard the protective factors? What if they had problems, they didn't wear their seatbelt, they were not responsible they've had multiple tickets? Well, then you're more likely to have a bad outcome. So it doesn't prove something bad is going to happen and you're going to have a terrible accident, but it may give some risk that will happen, and it's more likely if you have these factors. Let's apply this to the pancreas. The pancreas is an amazing organ, and it has a whole bunch of factors that protect it. Anatomically, it's protected by being in the back of the abdomen so it doesn't get traumatized. The acinar cells that make enzymes have a number of internal features. The duct cells have features to protect them. And there are also genes that pop up in case there is injury to protect the body, and there are antioxidants that can help protect the body if there's injury. There's also risk factors such as drinking alcohol, smoking, or genetics. And the alcohol, the risk is worse the more you drink. Smoking, it's worse the more you drink. Genetic factors you're born with, and those are not so easy to change, and you have no control over them. But there are things that happen, such as a gallstone or obstruction, that will trigger acute pancreatitis. There's metabolic things, high calcium or high triglycerides. Those are the blood fats that can be genetically determined that put you at higher risk. And there are obesity, age, race, and just things that happen out of the blue. These all suggest you're going to have a bad outcome, but it's really bad if you have some problems on the protective side and are missing protective genes or bad nutrition, or you have an anatomic problem. Each of these contributes to the severity of the outcome. And people with chronic pancreatitis are ones who have a combination of risk factors and loss of protection. However, it's not hopeless because we have the goal of balancing. How can you do that? Well, first of all, we want to immediately get rid of all the risk factors. And secondly, how can we strengthen the protective factors? For example, if there's a blockage, can we get around it with an endoscopy or with surgery? Can we strengthen the acinar cell or duct cell function? Can we add antioxidants and vitamins? And the answer is yes, and that can bring a person back into a balance, but we still need some medications that address some of the remaining problems. And this is a plug for the National Pancreas Foundation, which is dedicated to acute and chronic pancreatitis and pancreatic cancer research. So if you want to do something, give to the National Pancreas Foundation to solve these problems. So each of these is a way that we can protect it. So now let's get back to a patient. All patients are identical. We know that that is fiction. So what are the risk factors for pancreatitis in this patient beyond having alcohol? If she does have pancreatitis, what is the underlying cause? Is she at risk of progressing to recurrent pancreatitis or chronic pancreatitis? And which therapy will provide protection for her pancreas and bring her back into a balance? Because we have some ideas for everybody, but this person is unique and needs to have specialized precision medicine therapy. The answer is they usually have a combination of factors, including genetics. And so now we're beginning to understand that there's a whole bunch of things, both genetic and environmental and other factors, that come together in different combinations, and you have to understand what they are so your doctor can give you the right therapy. So this is precision medicine. These are the causes and the targets. So this is called TIGER-O. It's an acronym for all the different types of causes of pancreatitis, and they're all listed here, and your doctor goes through it. All you need to know is that there's a bunch of things that can go wrong. The reason that that's important is each of these cause damage by a different mechanism. And so if you're going to treat, you have to know what the problem is so you give the right treatment. This includes genetics, which is behind most of these factors. But understanding this allows us to give a different treatment to a different person based on what is driving the process and what is causing them to go from acute pancreatitis to recurrent to chronic pancreatitis. So there are multiple possible causes and one best treatment. And precision medicine is the art of figuring that out and delivering that. So for my part of the talk, I'd like to summarize that pancreatitis is complex and no two cases are alike. That alcohol is a major contributing factor for pancreatitis in some people, but not others. And the genetic background of each person can guide future treatment. And so I thank you for your attention. And what I'd like to do is I'd like to pass the microphone to Mark Haupt, who is the Chief Medical Officer of Ariel Precision Medicine. And he will talk a little bit about some of the genetic factors and how we think about them in order to provide precision medicine. Mark?
Thanks so much, Dr. Whitcomb, and good afternoon, everyone. First, before I get started, thank you for joining us. You may have noticed at the bottom of your webinar screen, there's a little Q&A button, and you can, through the remainder of the talk, if you'd like to ask questions about things you've heard or other things, we will have a Q&A session, question and answer session at the end of this for a few moments, and we will do our best to get through as many questions as possible, consolidate the ones that we see a consistent theme, and we will also answer some questions that we received before the webinar today. A little bit about my background. I'm a pediatric pulmonologist, and you may wonder how I got into the world of pancreatitis, and it was through helping to treat patients with cystic fibrosis with pancreatic exocrine insufficiency, and it transitioned into figuring out other ways to help those individuals through industry, as well as now working with Ariel Precision Medicine to understand the underlying cause of pancreatitis and using the tools we have available to identify better treatment strategies and options for patients and to answer questions about the why of this disease. Why do I have it? Why am I getting worse? What can I do to get better? So I'd like to tell a little bit of a story of Dave. If you can go to the next slide, please. It was in 1996 that Dr. Whitcomb in his lab actually identified the PRSS1 gene as a cause of pancreatitis. And it was, as David mentioned, there's a clear pattern in pancreatitis in some families where grandma had it, dad had it, and then the individual has it, and it's passed down in an autosomal dominant way. And it was in 1996 that the PRSS1 gene was identified, and at that time, Dr. Whitcomb and his group said that there was no rational or effective or preventive strategies that have been developed, and treatment consists solely of supportive care. Obviously, our goal is to try and change that these days, and unfortunately, there's still much of the care is supportive. And we hear so many stories about patients trying to find solutions, and we hope that genetics will be a component of that process. We can go to the next slide, Dave. So this was back then in 1996, what we understood about the genetics of pancreatitis. And if we go to the next slide, what we see now is that our understanding of the genetic contribution to pancreatic disease has blossomed significantly. And this is just a very brief representation of some of the genes that have been identified in patients who have pancreatitis. And of the patients who are here and the providers, you will recognize many of these. Some are still genes in which we are learning more about and what their role is in the pancreas. And the question mark in the middle represents that there are still many things we have yet to learn and are continuing to discover, and demonstrates the importance of collaborations and partnerships to gain a deeper understanding of the mechanisms of disease for pancreatitis. And if we go to the next slide, what you'll see is that we are now, through understanding what is the actual mechanism of pancreatitis, what are the cells involved, what are the different proteins, what are the different biologic processes, we can start to distinguish genes that are ones that are disease causing, the ones that perhaps a single gene, a single variant in a single gene, like the PRSS1 gene, is what's necessary to cause hereditary pancreatitis, perhaps the most aggressive form of the disease. Whereas other diseases contribute to the complex picture that Dr. Whitcomb has described, that perhaps in isolation, these genes are not problematic. They are common variants that we see in the general population. But when you start to layer different variants and different genes that affect different pathways within the pancreas, you can start to see that what may be the typical delicate biologic balance of the pancreas starts to tip towards the side of the bad outcome, as Dr. Whitcomb was showing. And if we go to the next slide, what we start to see, we can get into even more specific detail. I'm not going to go through each row and each X and show here, but what is starting to show here is that with time and with better technologies that we have available, we're starting to get very granular about what is the actual process that is causing the problem in the pancreas that's resulting in pancreatitis. Again, the reason this is important is that it hopefully may lead to discoveries for therapy or treatment options or ways to put the balance back to where it should be, so that either we reduce the progression of disease, prevent progression, ameliorate symptoms, decrease pain, any number of things. And as kind of a corollary to this, what was done in the cystic fibrosis world was that the CFTR gene was discovered in 1989. It was actually Francis Collins, who's now the director of the NIH, his lab, were the ones to first describe it. And now, only recently, in the last 10 years, has there been a specific therapy that has been approved for patients with cystic fibrosis with specific variants within that gene. And it started with that discovery and understanding the biology of the disease. And so again, understanding it, each patient at this level is so critical. If we go to the next slide. So we talk a lot about genetic testing and we wonder, well, who is it appropriate for? And there's certainly, as we're learning more and more, and as Dr. Whitcomb has showed, our understanding is that genetics contribute to many, many different forms of pancreatitis, even in patients who are believed to have or be labeled as only having alcoholic pancreatitis, when in fact there is actually a genetic cause to it. And at this time, we have to think carefully about how are we going to get the best information, whom is it going to be most helpful, and whom are we going to provide the best answers. And there have been recent guidelines that have come out that discuss who should be considered for this. And this reflects some of those that I'm sharing here. And I think a key theme that you see here is certainly early age of onsets, or in cases in which an individual has been thoroughly evaluated and there isn't a clear explanation, that it isn't an obstruction from gallstones or some other anatomic defect, but ones in which a thorough evaluation that includes imaging and laboratory studies, as well as understanding the family history, medication history, a really complete picture in which there's no clear understanding. And that's what we also mean by idiopathic. Certainly in cases where there's a family history in which we see two or more closely related individuals who have idiopathic chronic pancreatitis or recurrent acute pancreatitis, particularly those with early onset. And then in clear cases where we have individuals or families that have hereditary pancreatitis, which again is inherited in a predicted fashion with genes that are result in a highly aggressive form of the disease. Again, that's, just go back for 1 second, Dave, sorry. The discussion of who should be tested is really a discussion between, if your patients that are listening, you and your provider, to see if this is going to provide you the answers that you need to understand your disease. If we go to the next slide. Now, which tests to consider? There are multiple laboratories that offer genetic testing for pancreatitis. We are one of those. And different companies have different testing panels that are available, and those different testing panels include different genes, and there are different reasons for that. It's based on the scientific evidence or the understanding of what is going to be most clinically actionable, most clinically helpful, and to provide understanding. And so there is variability between those. There are some core genes like the PRSS1, CFTR, and CTRC, and SPINK1, which tend to run to be similar across the different panels. With the inclusion of other ones, really, there is significant variability. Some gene panels also include genes that are related to lipid metabolism. So as Dr. Whitcomb had mentioned, looking at these genes cause problems, if you have variants in these genes, cause problems with how you handle the fat in your blood. And that is certainly a risk factor or a contributing factor to pancreatitis, both disease onset and severity, and those are included in those. A key point that I will mention not only here, but on a slide coming up, is the importance of genetic counseling. Genetic counselors are specially trained individuals who help identify individuals and which tests are most appropriate, provide information about testing, what it means to get tested, what are the risks and what are the benefits, and also to understand the results of the test in the context of your disease, as well as your family history. And so they are incredibly important individuals in the genetic testing process and are an incredible resource to have available for testing. At Ariel, we do have genetic counselors available as part of our testing process because we believe it is so important. Go to the next slide. So what do the results mean? There's that genetic counseling point again. The genetic counselors, again, can help navigate what the testing means, the results, what it means for, potentially may mean for your family member, and potentially if additional testing is needed based on your family history, as well as the results of the tests. There may be other tests for other conditions that may be required as a result of what's found. A key point in understanding the results is the clinical context. And this is what we talk about, understanding family history, medication history, surgical history, the big picture, the progression of disease. Because again, a presence of a variant alone does not equal disease. And so we really have to look at what are the symptoms, what was the age of onset. And those are things that are important into going into interpreting and understanding the findings that are made through the genetic technologies we have available. What I have listed there are a number of different possible testing results. A positive result is that there was a variant identified in a gene that has been associated with the condition for the testing. And there's a variety of different levels of how we classify those, and that's beyond the scope of this talk. Negative report is in which only benign or common changes in the DNA are found. Those are not reported back. And that's a recommendation from the American College of Medical Genetics because there are so many common, what we call polymorphisms in the DNA, that the reports would be textbooks if we were to report every single thing. Sometimes we find things that are of uncertain significance, and these are variants that are perhaps new. They are ones in which there's conflicting evidence and understanding how it may contribute to a disease or not, or there just isn't sufficient evidence to be able to say something is positive, pathogenic, or benign. And the important thing to understand about variants of uncertain significance is that they are not intended to be clinically actionable. They are informative only. What can happen with the VUS, however, over time is that the classification may change. With additional patients being reported who have a specific variant, the classification may change to something like pathogenic, or maybe downgraded to benign. And this is the importance of working with a team of providers in a laboratory that continues to evaluate and assess the scientific literature and the data and the different modeling that we use, computer modeling that is, and the biologics of the laboratory evidence to understand how that classification may change and how those changes are communicated back to both providers and patients. And times there may be unexpected results in which you are looking for the association of a certain gene with a disease, but it may also impact a different one. For example, the ApoE gene is one that is talked about significantly. This is a gene that is associated with both familial hypercholesterolemia, so high levels of cholesterol in the blood, but has also been reported to be associated with early onset dementia and early onset Alzheimer's. And this evidence is constantly changing, and there's lots of debates about it, but that would be something that would be unexpected. You're thinking you're getting a test for pancreatitis, but then you're informed about the potential early onset of a neurologic disease. The next slide. So how to get tested? Talk to your provider, ask them questions. It may, as we've mentioned, it may aid in your pancreatitis care that there may be additional tests, either laboratory tests, genetic tests, tests for your family, that may help understand your condition. The different testing panels are different, and it's important to identify the one that is best for you, and genetic counselors are incredible resources to help with that. There are obviously limitations of testing. It's a biologic reaction. Sometimes it works. Sometimes there are additional samples that are required. There are unknowns. And obviously understanding that what is the benefit of having this information when perhaps a therapy is not yet available, and what does that mean for you and your family. And I think a really important one is to know that our understanding of genetics and their association with pancreatitis or really any disease is constantly changing, and it is changing rapidly. The number of genetic tests that are available has increased significantly in the last few years. The accessibility to them is increasing significantly, and it is a constantly moving and accelerating field, which is exciting because it's helping us understand disease and identify solutions for patients. If we go to the next slide. So I'll end it there. That was a quick overview. The hope is to be able to get to some of these questions. We have a number of questions pouring in. So Dave, if we go to the next slide, as I'm looking through the questions that have come through, these are a few that we received before the webinar. So Dave, would you be able to comment on when we talk about if you have a PRSS gene, a PRSS1 variant, could you not have pancreatitis? What does that mean?
Yeah, so this is a thing called penetrance, and what it means is if you take a group of patients that all have the same mutation, what fraction of them have the disease and what fraction don't. And it's been said in PRSS1 gene that there's about 80% penetrance. But when you look at families and people with this mutation, the average age of onset is about 10 years of age, where they'll have acute pancreatitis, and many of them then get recurrent acute pancreatitis and chronic. Some start having severe episodes of chronic or of acute pancreatitis at 1 or 2 years old. Others, we had a man that was 93 years old and was dying of another disease and requested that they take his pancreas out upon death and send it to us for evaluation because his father had pancreatitis and his children and grandchildren had it. And we did the testing, and he absolutely had the PRSS1 gene mutation, and his pancreas was perfect. It looked better than most 20-year-olds. And the reason for that, we never could figure out, but we just see that this happens from time to time. We know from studying cystic fibrosis that there are other genes called modifying genes, and a lot of work has been done on that as well, because patients that have the most common gene have very different outcomes. And so it's a little bit complicated, but we are able to begin teasing out the reasons why. And even for PRSS1, we're beginning to learn some things about what causes the symptoms and what doesn't. One other thing I'd like to say about PRSS1 is that when we first studied the families, we found that the rate of pancreatic cancer by age 70 was 40%. And that was terrifying. But what we also found is it seemed to be associated with smoking. And so we told the family about this problem, and guess what happened? They quit smoking. And we just did a 20-year follow-up, and it turns out that the rates of pancreatic cancer by age 70 had dropped down to very low levels, probably around 5 or 6% by age 70. And so it's a little bit higher than you'd expect in the general population. But this is where the teeter-totter comes in, and what can you do to tip the balance more toward safety and away from danger? And amazingly, just a simple thing like this was able to save many lives from pancreatic cancer.
Dave, we've received a lot of questions about obstructive pancreatitis and sphincter of Oddi dysfunction, and questions about, is there a role, or can genetics contribute in those cases in which a patient may have some anatomic issues? And then additionally, in the cases that are labeled as obstructive, if the gallbladder is taken out and a patient continues to have recurrent episodes, what role might genetics have in those kinds of cases?
Yeah, so this is a really part of the dilemma about being a physician, is that we make decisions based on best guess and what works in groups of patients. What we know is that if you've had an episode of acute pancreatitis and you don't have your gallbladder out, you're at high risk of recurrent attacks. If you take the gallbladder out, that's markedly reduced, but it doesn't erase the risk. So the assumption is that the pancreatitis came from gallstones, but if you take the gallbladder out and you're still having it, then that probably wasn't the reason. The majority of the time it is, sometimes it's not. And then on further evaluation, we find that the person actually has mutations like a SPINK mutation, a CFTR mutation, or others that are actually causing the problem. The other anatomic problem is called pancreatic divisum, and that's where the channel that takes the digestive enzymes to the intestine doesn't hook up correctly, and it causes obstruction. And it looks like it's a plumbing problem trying to get the digestive enzymes out. And so if you have the duct sort of pinched off just before it goes into the intestine, that causes high resistance to flow, which you can overcome if the ducts can really flush a lot of fluid. But if there's some mutations that damage the ability to really give a full flush, then it looks like that puts people at risk. Most of the obstruction that we think about is gallstones, and then with older age, there are types of tumors or cancers called IPMNs that block the duct, and they can cause pancreatitis as well. So we have to take a holistic view. If you look at only the genetics, you're not going to get the right answer. And if you look at everything but the genetics, you're not going to get the right answer. So they work together, and in each case, we can sort of sort it out.
Great. So one of the other questions we received before this webinar is, there always another variant that goes along with SPINK1? Dave, if you could bring up just click next. So this picture may look like a drawing my 3-year-old son has done recently while we stay at home with dots and colors everywhere, but this is actually a very informative image of work that we've been doing. And I'll give a quick explanation of it, then I'll let Dave dive into the details here. That if you look at this picture, each of the larger circles, and I'm not sure if you probably can't see my mouse, but each of the large circles represents a different one of the genes that has been associated with pancreatitis. And what we've done, they've been organized by where they cause the impact in pancreatitis. So the acinar cells, those are the ones that make all the digestive enzymes, the duct cells, which is where CFTR is located and produces all the pancreatic fluid that helps flush the ducts. And then there are some other, the other circles relate to what's happening inside of those different cells. And these are things that are throughout the whole body and how they relate to how proteins work through the cell and then injury and stress response. And each one of the little dots that's of the same color of the big dots represents a variant in that gene. And the lines between those dots represent that those variants appear together more often than chance. So they're showing up together. And so what you're seeing is that there's this network of variants that appear between genes or even within genes that are showing up. And these information was taken from 100 patients with pancreatitis that we went back and we looked at to see what combinations of variants and things are we seeing. And what you can see, even with the SPINK1 gene, which is over on the right-hand side, there are some variants in SPINK1 that tend to show up with CTRC variants. And we also commonly see combinations with SPINK1, CTRC, and CFTR variants. And so again, it gets to the point of this complex picture of having multiple variants and multiple different genes affecting different pathways and tipping that balance. Dave, do you have additional thoughts to add to this?
Yeah, I would say that one of the problems is if you pick this particular variant, and this number is a reference sequence, so everybody knows exactly which variant you're talking about out of the 3.5 billion ones that are known. If you look at one, you can't understand what's going on. You have to see how it fits in with other things to determine whether or not it's more likely part of a damaging problem or if it just is random in the population.
Great. If you can click next again. Another question we have is, my twin brother has diabetes and I have chronic pancreatitis. Is this because of genetics expressed through behavior? So I guess talking about twins and the role of genetics and perhaps environmental and complex disease. Dave, could you comment on that, please?
Wow, that's a very interesting question. And the answer is that we don't know for sure. My laboratory at the University of Pittsburgh, we have been studying why people get diabetes with pancreatic injury. And we're discovering some very interesting things. As I showed you, about 35% of patients with acute pancreatitis or recurrent acute pancreatitis develop diabetes. And it was thought that their islet cells were destroyed, but yet the pancreatitis can be relatively mild. We did a study to look at all of the genes associated with type 2 diabetes, and lo and behold, the 30% that had diabetes had a bunch of type 2 diabetes genes that suddenly began misfunctioning because of the inflammation surrounding them. So the patients with pancreatitis that had risk of type 2, it pushed them over the edge much earlier at a 3 times higher rate than expected. So it was a pretty big effect. But diabetes is very complicated. There are hundreds, actually there's more than 400 variants that are associated with diabetes. And so that is a big problem. The second thing is why one twin would have pancreatitis and the others don't. We did a study about 15 years ago, and looking at these large hereditary pancreatitis families, we found a number of twins that were identical or just paternal twins. And it turns out that 80% of them had pancreatitis and 20% didn't. But there were people who had very severe hereditary pancreatitis and their twin had nothing. And they were together all the way through college. Their environment was the same, and they were identical twins. We know also that even though people are identical twins, their immune systems generate a number of variants on their own. So the genetics inside of the immune cells get scrambled up continually, not just as the first cells are dividing. And so their immune systems are quite different, and that suggests that may contribute to that as well. There are also some freak environmental things that'll happen. Like one person will get a virus, not that anyone's thinking of viruses now, and the others won't, and that may trigger the process as well. So it's a combination of factors, but they tend to kind of go together. Twins tend to have the same type of thing. One of the most interesting things is that in the Scandinavian countries, they looked at individuals that were identical twins. What was the probability if one of them got pancreatic cancer, would the other one get pancreatic cancer? And the answer is no, that you'd usually get a different type of cancer like colon cancer or breast cancer. So there's a lot of other factors that are also important. But one of the things that's a little bit frustrating for everybody is something we've heard on the news with this coronavirus. And we see that there are therapies that are very promising and exciting. And Dr. Fauci keeps saying, we have to get the data, we have to do the clinical trials. And he's right. And it's so hard because it takes a long time and a lot of effort. The coronavirus has the advantage of the United States government is borrowing from the future in a huge way to solve this as soon as possible. In pancreatitis, we don't have that urgency on a national level, but you can donate to the National Pancreas Foundation that's working hard day in and day out to solve some of these problems, because we do need the data, we do need trials, and we really do need to find some more answers. So we're working as hard as we can, and we just hope that this will come around to really make a huge difference.
I'm going to be mindful of time here, so I'm going to ask you two more questions, Dave, and then I'll go to the last slide, and we'll show some resources and a couple of kind of closing comments. So one question is, can you talk about the risk of developing pancreatic cancer in individuals who have a hereditary pancreatitis PRSS1 variant and have recurrent acute pancreatitis or chronic pancreatitis? What does that progression look like? Does age factor in? What about smoking? What does that clinical course look like in general?
Yeah, so that's a great question, and I think we're learning a tremendous amount. The most important thing is it turns out that the risk of pancreatic cancer does not correlate with the number of episodes of acute pancreatitis or the severity of fibrosis. So they're true and unrelated. It's like the pancreatitis triggers a process that can lead to cancer, but there's a number of other steps that are also important. What we learned is the environmental factors are extremely important. And so things like a healthy lifestyle, no smoking, stay away from alcohol, plenty of vitamins, especially green vegetables like broccoli and multivitamins with antioxidants is the best defense, because the cancer requires toxins that cause DNA damage. It's an acquired genetic problem in which DNA damage occurs. And if you can minimize the DNA damage and optimize repair, then as we've recently shown with hereditary pancreatitis, the rates of pancreatic cancer just plummet. So that's the best advice I can give right now.
And then kind of related to the last question there, before we go to showing some additional resources and things and to finish up, there have been questions about, should I get testing? Is testing important if I, to help get things in balance? If I eat healthy, if I don't smoke and I don't drink, does genetic testing matter for me? Is it going to help me if there aren't any specific therapies yet? And so the question that's on the screen, what happens next? What do I do? Who do I see? So what are kind of your closing thoughts on the role of, I think, genetic testing for patients with pancreatitis at all, the various stages, and what do you do next with this information?
So that's a really, really important question. And so the short answer is that it's an individual decision. Some people want to know and some people do not want to know. And we certainly respect that, and we encourage everyone to eat healthy and to have a healthy lifestyle. The important thing about getting testing is not only does it give you an answer, it has some prognostic value as well, so that it helps you understand the kinds of specific things that you want to do or avoid. Secondly, is that as we learn more and more about these diseases, there may be specific therapies, and we've certainly got some in the pipeline, that are going to be very effective in one type of pancreatic disease and not in another. And so making sure that you understand what your genetics are and are able to keep track of what's emerging, and volunteering to be part of a trial to see whether or not the new therapies work. Those are the studies that have to be done that may have immediate benefit to individuals and can help others as well. So that's why we are appreciative of people who do want to know what's going on with them. They want to know their pancreas, but they also want to participate in ongoing studies just to find out what kinds of problems are developing, if there are specific things that are unexpected, if there are things that seem to be working. All that information is data, and the data is key to solving these diseases. So I hope that answered the question. And if you have more questions, we do have some resources here. And we're also found out we had so many good questions that we are considering additional quarterly webinars, and we would appreciate your feedback as to the types of things that you appreciate and need, and what you would like us to focus on in the future.
Yeah, thanks, Dave. And there have been a lot of questions about, will this be posted or will we share these slides? We are currently working on the best way to be able to share this information and to make it available for anyone that's interested. Any of the websites for the National Pancreas Foundation, Mission Cure, many of you whom are familiar, as well as our own website. We have a lot of information about pancreatitis, as well as on our website about genetic testing in general. One quick question, there was a question here about where can I find a clinical trial in my area. If you go to clinicaltrials.gov, that's clinicaltrials.gov, that is a national repository of clinical trials in your area. I would also ask your provider if there are any ongoing studies at your institution for which you may be eligible. Obviously, during these trying times, there are a lot of questions about COVID-19 and what role it may play in patients with pancreatitis. We've listed some resources there. We have recently written a blog post on our website talking about pancreatitis and COVID-19 with a list of resources for both information, for mental health support, how to reach out for help. The gutscharity.org.uk website has a really outstanding post on it as well. And obviously the CDC and your local state health departments are places to look for questions. There has not yet been any specific reports or papers or studies about COVID-19 and pancreatitis, but we will certainly keep our eye out for them and our ears to the network to see what we can find out. So with that, thank you all for attending and spending your afternoon with us. We hope the information you heard here today was informative. We hope it prompts more questions with your providers, with us, with the community in general, as we all work together to find answers and to help patients with pancreatic disease. So again, thank you for joining us. We will follow up with where we will be sharing this presentation and slides, and we'll also do our best to answer the questions we weren't able to answer in the Q&A today that we received in that posting as well. So for those of you who we didn't answer your question, our apologies. We'll do our best to get to it. And with that, we will end the webinar, and stay safe and be healthy.